The following podcast is part of a certified educational activity titled Navigating the Path to Next Generation Anticoagulation Strategies, Rising to the Challenge of Unmet Needs in SSP and AF. Access the entire activity and complete the post-test at peerview.com/VBD860. Downloadable slides and practice aids are also available.
Welcome to this program entitled Navigating the Path to Next Generation Anticoagulation Strategies, Rising to the Challenge of Unmet Needs in Secondary Stroke Prevention and Atrial Fibrillation. I'm Jeffrey Wykes, Distinguished University Professor at McMaster University, and with me today is Roxana Moran, who is a Mount Sinai Endowed Professor in Cardiovascular Clinical Research and Outcomes. Now, the goals for today are to learn about the unmet needs in patients with stroke and atrial fibrillation, despite the current standard of care. We're going to show you how factor 11, 11A inhibitors have a distinct mechanism of action that may render them safer than currently available anticoagulants. And we're going to talk about patient-centered, team-based strategies that may improve effective thrombosis prevention across the continuum. So let's start by addressing the gaps in anticoagulation with factor 11-based therapies. We've seen a tremendous advance in antithrombotic therapies over the years. It's hard to believe that the direct oral anticoagulants, the factor 10A inhibitors like apixaban and edoxaban and rivaroxaban, have now been in use for about 15 years. And they have replaced vitamin K antagonists like warfarin for many indications. And now we're in a new era, the era of the factor 11 inhibitors. Although the direct oral anticoagulants represent a tremendous advance, bleeding, or either established bleeding or the fear of bleeding, leads to the underuse of anticoagulants in eligible patients with atrial fibrillation, and often the inappropriate use of low-dose direct oral anticoagulant regimens. And both of these lead to unprotected patients. And some examples here. In a meta-analysis, we see that up to 50% of patients who are at risk for stroke are not receiving anticoagulant prophylaxis. In a registry, the Orbit-AF2 and Garfield registries, we see that at least a third of eligible patients with atrial fibrillation are not receiving anticoagulant prophylaxis. And we know that without anticoagulation in patients with atrial fibrillation, the risk of death and stroke is higher than it is in those who are anticoagulated. So we need to do better. So how can we do this? And this then requires an understanding of where factor 11 acts in terms of thrombosis and hemostasis. So this slide is to remind you that coagulation can be activated via two distinct pathways. The extrinsic pathway, or the tissue factor pathway, is the pathway that's initiated when, for example, an atherosclerotic plaque ruptures and tissue factor is exposed, and 10A and thrombin are generated and a clot is formed. The intrinsic pathway, or the contact pathway, is the pathway that's activated when blood comes into contact with foreign surfaces, such as a stent or a heart valve or a catheter. And this also leads to factor 10A generation and thrombin generation and clot formation. And factor 11 resides in that intrinsic pathway. Now, this slide tries to distinguish between pathologic thrombosis, which is predominantly an intravascular event where clots form in the center of the blood vessel and block blood flow, compared with physiologic hemostasis. This is the procedure by which clots are formed to stop or to plug holes in the blood vessel from inside injury. And this is mostly an extravascular event where the clots form to seal the pole in the blood vessel. Now, if we look first at hemostasis, this is triggered by the high concentrations of tissue factor that surround the blood vessel in that hemostatic envelope, and that leads to explosive thrombin generation and fibrin formation and platelet activation to form that hemostatic plug in a process that largely does not involve factor 11. Contrast this on the right to thrombosis or intravascular clotting, which is triggered by the exposure of a small amount of tissue factor inside the blood vessel. This results in the formation of a little bit of thrombin, which then feeds back to activate factor 11 and amplify factor 10A and thrombin generation to cause that clot to grow. And this then, as the clot grows, it plugs up the vessel and causes a heart attack or a stroke. Now, the DOACs that we have now, like apixaban or dabigatran or rivaroxaban, they target clotting factors in the common pathway, either factor 10A or thrombin. And the common pathway is involved in both hemostasis and thrombosis. Therefore, if we target clotting factors in the common pathway, we will attenuate thrombosis, but will also, because of the hemostatic effects, will also have an effect on hemostasis that can lead to bleeding. Contrast that to factor 11 inhibition. Factor 11 is mostly dispensable for hemostasis, but essential for clot expansion in the thrombosis pathway. So factor 11 inhibitors can reduce thrombosis with little or no effect on hemostasis. At least that's the promise. Now, what evidence do we have to support factor 11 as a target? Well, subjects with congenital deficiency of factor 11 have a reduced risk of thrombosis and rarely experience spontaneous bleeding. And genetic epidemiology studies using Mendelian randomization or large cohort studies show that the risk of thrombosis is higher in individuals with high factor 11 levels and lower in subjects with low factor 11 levels. So there's a relationship between the risk of thrombosis and the factor 11 levels. And finally, in animal studies, if you knock out factor 11 or inhibit factor 11, can attenuate clotting in arteries and veins in response to an injury. And in all bleeding models tested, there's no increase in bleeding. Factor 11 inhibitors have undergone evaluation in phase 2 and now phase 3 trials in many indications. We're going to talk about atrial fibrillation and secondary stroke prevention today, but other indications have also been investigated as shown on this slide. Now, the factor 11 inhibitors that are in phase 3 evaluation come in two flavors. We've got a monoclonal antibody, abelacimab, which binds to the catalytic domain of factor 11 and blocks its activation by factor 12A and by thrombin, and also blocks its activity. And we've got small molecules, asundexian and milvexian, which bind reversibly to the active site of factor 11A and inhibit its activity, much like the DOACs bind to the active site of factor 10A or thrombin and block their activity. Now we'll move to factor 11 inhibitors in ACS, and I'll move to you, Roxana.
Thank you so much, Jeff, for that fantastic background information with regard to factor 11 inhibitors. The area that I believe we felt very, very strongly that there was an unmet need is in the acute coronary syndrome patients. And as you stated, it's been a very long time, over 15 years now, that we've had the same P2Y12 inhibitors and antiplatelet regimens in our patients with acute coronary syndromes, and some promise with factor 10A inhibitors. Unfortunately, with regard to that, we've had residual events, but also we had some bleeding. So the rationale in terms of factor 11 added to antiplatelet regimens with regard to the mechanism of action that you beautifully described seems extremely beneficial. Can you imagine that we could have an anti-ischemic effect without increasing bleeding? It almost seems like the most fantastic regimen that could be available to our patients, especially after an acute MI, knowing that the cumulative risk amongst patients who are a year out after an acute MI is still elevated and continues. These curves continue to show residual events. So the approach of targeting thrombus propagation while maintaining hemostasis just seems to be perfect for our patients with an acute coronary syndrome or after a myocardial infarction. And with asundexian, there was the phase 2 study of Pacific AMI. Here, you could see beautifully that the bleeding outcomes with the use of asundexian versus placebo in patients with an acute MI who were already treated with dual antiplatelet therapies seemed to be quite interesting, with a 9% rate in those patients with placebo and no difference with 10 or 20 milligrams, and maybe just a little bit of a slight increase in asundexian. In that study, 2 patients had an intracranial hemorrhage, one with the 50 milligram and one with placebo. There were no fatal bleeding. So it just seemed to be extremely favorable. And you can see the efficacy outcomes in this Pacific AMI study. On top of DAPT, the dose-dependent factor 10A inhibition without increasing significant bleeding was shown, but there was no clear signal, although you're really underpowered in these studies, as you can imagine. But given the very few MACE events that were shown here, we really can't make anything out of those ischemic events. But importantly, the phase 3 trial was not pursued with asundexian. Now, if we move to milvexian versus placebo with patients with an acute coronary syndromes, a phase 3 study was underway with the almost full evaluation of these patients with an acute coronary syndrome, including STEMI, non-STEMI, unstable angina, and biomarker positive patients who come in who were being planned to be treated with some duration of antiplatelet regimens, dual antiplatelet regimens, and they were randomized to milvexian versus placebo on a 1-to-1, and this was within 7 days of their acute coronary syndrome event, with a MACE endpoint of cardiovascular death, MI, ischemic stroke, and a primary safety endpoint looking at those important bleeding endpoints of BARC-3C and 5. Importantly, on November 14th, 2025, based on the INDMC, IDMC recommendations, the LIBREXIA-ACS study was stopped because of the unlikeliness to be able to show or achieve its primary endpoint of the major adverse cardiovascular events. So, Jeff, I'm back to you for looking at stroke prevention.
Thank you, Roxana. So let's move to secondary stroke prevention. And I want to remind you that Ischemic stroke is the second most common cause of death, and there are many ischemic strokes in the United States and worldwide each year. Now, the stroke that we're talking about here is the non-cardioembolic stroke. So to put things into perspective, if we take all strokes, about 85% of them are ischemic strokes. And of those ischemic strokes, about 75% of them are non-cardioembolic strokes. So we're not talking about the strokes that we see in patients with atrial fibrillation. We're talking about the other types of stroke. And the unmet need here is that with current standard of care, which focuses on antiplatelet therapy, after that stroke, there's a high risk of recurrent stroke. And that recurrent stroke is often more disabling or more often fatal than the first stroke. So we really need to do better to protect our patients with non-cardioembolic stroke from future events. Now, current guidelines recommend dual antiplatelet therapy with aspirin and clopidogrel, or possibly aspirin and ticagrelor, for a short period of time, usually 21 days, followed by single antiplatelet therapy, usually with aspirin thereafter. We can see in terms of the patterns of antiplatelet prescriptions that although there's increasing use of dual antiplatelet therapy at discharge, we still need to do better to follow the guidelines. Now, why would we think of adding an anticoagulant on top of antiplatelet therapy in patients with stroke? Well, we have data from the COMPASS study. Remember, this study enrolled patients who had stable coronary or peripheral artery disease or cerebral artery disease and randomized them to one of three groups: aspirin alone, rivaroxaban alone, or the combination of aspirin plus rivaroxaban. This is low-dose rivaroxaban, 2.5 milligrams twice daily. And you see on the left here that combining rivaroxaban with aspirin reduced the risk of ischemic stroke significantly compared with aspirin alone. The problem with this approach is that there was an increased risk of bleeding, as shown on the right-hand side, including a small increase in fatal bleeding. So the idea here with factor 11 inhibition is that can we do this more safely with an 11 inhibitor because it has an effect on thrombosis and minimal effects on hemostasis. Now, there were two phase 2 studies, one with milvexian and one with asundexian, in patients with non-cardioembolic stroke. These were dose-ranging studies comparing different doses of the small molecule inhibitors with placebo. The primary outcome in both of these studies was the incidence of recurrent overt and covert stroke. So recurrent symptomatic stroke and covert stroke that was detected on repeated MRI brain imaging. Neither study was positive, so these inhibitors had no effect on the covert stroke, but they appeared to have an effect on symptomatic stroke. So these phase 2 studies prompted two phase 3 studies: the LIBREXIA-STROKE study with milvexian, about a 15,000 patient study looking at milvexian at a dose of 25 milligrams orally twice daily compared with placebo on top of antiplatelet therapy. And the investigators can choose the antiplatelet therapy. And asundexian in the OCEANIC-STROKE study Again, comparing 50 milligrams once daily of asundexian with placebo in patients with non-cardioembolic stroke, about 12,300 patients in the study. And in both of these studies, the primary outcome is a recurrent symptomatic stroke. So here's the design of the OCEANIC-STROKE study, a one-to-one randomization to asundexian in the dose I mentioned versus placebo, and the primary efficacy outcome, the time to first occurrence of ischemic stroke, and of course the safety outcome is bleeding. Now, the results of that OCEANIC-STROKE study indicates that the trial was positive, meeting its efficacy outcome of the asundexian, reducing the risk of recurrent stroke, and its safety outcome, doing so without an increase in bleeding. The LIBREXIA-STROKE study is a little bit behind the OCEANIC-STROKE study, a similar design, one-to-one randomization to milvexian or placebo. And given the positive results with the OCEANIC-STROKE study and the similar design of the LIBREXIA-STROKE study, and the fact that, like asundexian, milvexian also inhibits factor 11A, we're hoping for a positive outcome from this study as well. So here we move to our first case study, and this one focuses on secondary stroke prevention. And here we have a 70-year-old woman with right-sided weakness, CT evidence of an infarct in the left middle cerebral artery distribution. She has a history of hypertension and dyslipidemia, but no history of atrial fibrillation or evidence of carotid artery disease. She had a good outcome with thrombolytic therapy, and now we're thinking about secondary stroke prevention. So the guidelines would recommend that she receive dual antiplatelet therapy, usually with aspirin and clopidogrel, for 21 days, followed by single antiplatelet therapy, usually with aspirin. But could we do better? Could we do better than this approach by adding a factor 11A inhibitor? And that's the promise for the future. So, Roxana, let's move to atrial fibrillation.
Thank you, Jeff. The idea of balancing cardioembolic stroke prevention and bleeding risk is incredibly important because here we are now in thinking about patients, and some of these patients, by the way, who have atrial fibrillation and need the oral anticoagulation for stroke prevention might even be on top of that, might even be on antiplatelet therapies, especially if they are undergoing a stent procedure, for example, because these things happen for coronary events. So this becomes the biggest dilemma and the Achilles heel in terms of how do we balance the bleeding risk of these patients who are often older with many risk factors for bleeding, but also at a quite of a high rate of ischemic stroke, a cardioembolic stroke. So to me, this area is incredibly important. And imagining that we could have a possibility of moving forward with patients who have AFib with the use of factor 11 inhibitors is one that to me is incredibly intriguing, because here's where the balancing equation is quite important. And as you heard, and importantly, Jeff discussed the ischemic stroke with 77 million affected, and as the second most important cause of death. Atrial fibrillation is not far behind with 53 million people affected and about many deaths that we are seeing. So imagining that we could make that balance work in terms of the cardioembolic risk and the bleeding risk in these patients is a very, very important area of investigation. And factor 11 just seems to be perfectly right there, doesn't it? The landscape you saw before for ischemic stroke, about 87 or so percent of all strokes. And about of all of those ischemic strokes, about 25 to 30% being cardioembolic, like atrial fibrillation. So asundexian has definitely imagining that this could be fantastic. And in fact, the Pacific AF study did show less bleeding with asundexian versus apixaban, but it was underpowered for efficacy. And it just seemed like it was the very best place to go. And you could see this here with the asundexian at 2 doses only, 20 milligrams and 50 milligrams, and then the pooled analysis compared to apixaban. And you see that the dosing evaluation is only between 20 and 50 milligrams. And then they moved ahead, and the number of patients are quite small. You see them, 250 or so patients in the 2 doses, and the total number of patients, about 750 patients. But it's a promising strategy to minimize bleeding in AF patients and perhaps even have an important effectiveness compared to apixaban. So if you think about this and knowing that with patients on factor 10A or apixaban, we've had on top of maybe antiplatelets, there's been imagining that you could really go up against this. This is the OCEANIC-AF study, the phase 3 program with a sample size of 18,000 patients, with an ITT group of about 14,800, randomized to the 50 milligrams QD of asundexian once a day compared to apixaban twice a day. So this was for the primary efficacy endpoint of stroke or systemic embolization, and ISTH major bleeding for the safety endpoint. And the clinical benefit endpoint was there too. But we all remember in 2023, in November 19th, that the IDMC recommended stopping this because of the inferior efficacy of asundexian versus apixaban. And these data were shown and presented by Manesh Patel and Dr. Piccini over at the New England Journal of Medicine and in the scientific sessions. And we saw the separation of these curves in favor of apixaban with the extremely low event rates. And you see that here between the 2 groups, and the IDMC doing the job that they needed to do, showing this. And the reason is still under exploratory evaluations. We're really not sure, is this the wrong dose of asundexian, et cetera, knowing that the early studies were just in 2 doses only, and the higher doses weren't being evaluated. But I think this is going to be further explored as we better understand what's going on here. Now, moving to milvexian, another small molecule, here with 100 milligrams BID compared to apixaban 5 milligrams BID, we have over 20,000 patients who have been randomized and will be evaluated again for the primary efficacy endpoint of prevention of stroke and systemic embolization, and a safety endpoint of ISTH major bleeding that will be evaluated. We're waiting for these results, and so far, this study has not been stopped for any evaluation.
Thank you. Another agent that's being investigated in atrial fibrillation is abelacimab. This is the factor 11 directed antibody. And a phase 2 study, the AZALEA-TIMI 71 study, randomized patients with atrial fibrillation at moderate to high risk of ischemic stroke to 2 different doses of abelacimab, which was given subcutaneously on a monthly basis, or to rivaroxaban. This was an event-driven study, underpowered for efficacy, focusing mainly on bleeding as the outcome. And the study was stopped early by the IDMC, not because of lack of efficacy, because it's underpowered for efficacy, but because of a overwhelming reduction in major and clinically relevant non-major bleeding with abelacimab compared with rivaroxaban. And even major bleeding was reduced with abelacimab compared with rivaroxaban. And I found it interesting that GI bleeding, which can occur with direct oral anticoagulants, was mostly dialed out with abelacimab compared with rivaroxaban. So these promising results have led to the phase 3 LILAC-TIMI 76 study. This is a different design from the trials that Roxana just spoke about, in that this study looks at high-risk patients with atrial fibrillation who are considered unsuitable for currently available oral anticoagulants. And such patients are then randomized 1-to-1 to abelacimab, which is given subcutaneously once monthly at a dose of 150 milligrams, or to placebo. And the primary efficacy outcome is that same systemic embolism and stroke, whereas the safety outcome is bleeding. So an interesting design, 1,900 patients. Hard to find these patients, but the study is well underway. So if we look at the phase 3 studies that are currently underway in atrial fibrillation, we have with milvexian, the LIBREXIA atrial fibrillation study, over 20,000 patients, comparing 100 milligrams twice daily of milvexian with apixaban at the usual doses. And we have the LILAC-TIMI 76 study, which compares abelacimab with placebo in the high-risk atrial fibrillation patients who are considered ineligible for currently available oral anticoagulants. And we had the OCEANIC-AF study, which has stopped. So we have these two studies in atrial fibrillation, which are underway, and we're very excited to see the results. So, Roxana, maybe I'll pass this case on to you.
Yeah, this is a great case, right? And I mean, much like the other case, these are the cases we're going to be seeing as clinicians. Here's a 79-year-old woman with atrial fibrillation who has coronary disease, heart failure, hypertension, type 2 diabetes with a creatinine clearance of 60 milliliters per minute and a weight of about 80 kilograms. She appears frail, has history of falls, has had a recent GI bleed due to gastric ulcer. And this is the typical patient that is the place where we absolutely will be very, very worried about bleeding complications, but also very much at risk for stroke. The promise of factor 11 in these patients is tremendous, and we're waiting to hear. It's unfortunate that in the OCEANIC-AF study was stopped, but we're still waiting to hear from LILAC as well as the LIBREXIA-AF study. But very importantly, right now, before we have these available, what we're doing is using these very important patient-centeredness with bringing the entire team together to implement a treatment plan with duration of therapy and how we could look at this. One of the things that I'm most upset about with this patient population is when physicians and clinicians and healthcare providers are so scared about the bleeding that they do not anticoagulate these patients. And this is the piece that I believe is tremendously important.
Absolutely, Roxana. And, in conclusion, I think we have a way of addressing that dilemma, because if targeting factor 11 can reduce the burden of thromboembolic diseases, including atrial fibrillation and secondary stroke prevention and non-cardioembolic stroke, while preserving hemostasis, then we'll be able to better treat these high-risk patients. So to find out what the benefit risk profiles are of these exciting new agents, we'll have to await the results of the phase 3 trials. And fortunately, we'll have the results of the OCEANIC-STROKE trial available early in February, and we're all excited to see them. Thank you very much for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from the Bristol-Myers Squibb and Johnson & Johnson Alliance. To access all materials for this activity, visit peerview.com/VBD860.